Welcome back to season 4 of Authentically Peculiar with Marcia. I am elated because for 3 years I have been trying to get a medical professional to come and talk to us about women's bodies, women's changes, and dear God, how we get past the hot flashes and all the other stuff. So, my guest tonight is Dr. Paula Orr. She is a native from Bmore, Baltimore, Maryland,
Right, that's
but
right.
she calls Charleston home for the last 26 years. For 24 of those years, her passion has been in women's health as the physician and owner of Charleston's Women's Wellness Center and the medical director of Charleston Health and Wellness MediSpa. Her private practice specializes in preventative and alternative health for women in gynecology that includes bioidentical hormone replacement therapy, which we're going to get into, and weight management, which we're going to get into. Dr. Orr graduated from medical school from Wayne State University in Detroit. She completed her residency in Cook County Hospital in Chicago and served as the administrative chief resident for the Department of Obstetrics and Gynecology. She's very active in the community. She serves on the board of numerous organizations, and she served on the board of the Coleman Charleston affiliate of the Susan G. Komen Foundation for 3 years, as well as the only only African American on the board of trustees for the Medical University of South Carolina for 8 years, from 2002 to 2010. She's received all kind of accolades from the community. She is very active in the Charleston Alumni Chapter of Delta Sigma Theta Incorporated, the National Council of Negro Women, Bethune-Leonard Section, and the Charleston Chapter of the Links. She is currently serving as the Southern Area Health and Human Services Chair to the Other Links Incorporated, and she attends Royal Missionary Baptist Church. She has amazing 4 children and a grand pup. So, Dr. Orr, thank you for your yes and joining me today.
Thank you for having me for this important discussion.
Absolutely. Anything you want to prepare them for before we get started, or you want me to just dive into our questions?
Well, I'll just say that, I have been doing just gynecology with an emphasis on menopausal medicine for the last 10 years. So
Mm,
I feel like, this has now become my new passion. At
yeah.
every stage of our lives, we have to sort of pivot and transition. And so for me, this was my pivot and transition
Mhm.
because I was menopausal, perimenopausal, and approaching that. And
Right.
so it's been my focus for the last 10 years,
Nice.
specifically around menopause.
And I love, and I shared this with you. I said, when you talk about menopause and what's happening with women's body, your passion flows through. It's like your skin begins to glow because of you educating women on the importance of really understanding. It's always been a taboo in the Black community to talk about women's health and what our bodies go through. What are some things that you would say to debunk myths about menopause?
There's so many, right? So let
Mhm.
me first start by saying that um, menopause is one of those areas in women's health that where there are not a lot of studies. So there's
Mm,
one very large study that was ongoing in the late 90s, and it
okay.
halted suddenly because they determined or they believed that there was a causative link between hormone replacement therapy and breast cancer and heart attacks and strokes. So they
Mhm.
never completed the study, but they went on TV. They had this big, huge press conference. Not even the people in the study and the people conducting the study knew that they were going to do this, and then
Mhm.
that this was what was happening to women as a result
Wow.
of hormone replacement therapy. So fast forward 30 years later, we now know that that study had a lot of flaws in it. But
Mm,
unfortunately, what's happened is there's not been any substantive studies around menopause since that study was halted in 1995. So that
right.
tells you how little information there is that's out there
Mhm.
for people to kind of grasp and understand. So for that reason, people don't know what they don't know.
Right.
They fear what they don't know, and they don't really know what to ask. And so
Mhm.
as we talk about menopause, and particularly in African American women, you said it at the beginning, is that we always have had this silence around our body,
Mhm.
our health,
Mhm.
and we feel like it's one of those things that everybody goes through and we should just suffer through it. So
Mhm.
feel like, oh, I'm getting older, I'm not having a period anymore. So my mother went through it, she didn't take anything. My grandmother went through it, she didn't do anything. And so I should too. I shouldn't even consider doing something to alleviate the suffering and the discomfort that I'm having.
Mhm.
So I think though that's the bigger issue around this, is that there's not a lot of information,
Okay.
and then people don't know what to ask. And
Mhm.
piece is, unfortunately, there's still not a lot of physicians who are even comfortable with the conversation,
Interesting.
because they're still um using the rhetoric from 30 years ago, that
Oh,
hormone
I got you.
bad, it's going to give you breast cancer, it's going to give you a heart attack and a stroke. And so they're not giving up to date information about what
Mhm.
the value and the benefit of hormones are. And let me just say this, I am not um I am not here to say that everybody should be on hormone replacement therapy, because
Right.
choose, right? And there are
Mhm.
things that you can do that are non-hormonal that can be of benefit to help alleviate the discomforts and the sufferings that you're experiencing. But if you were to choose hormone replacement therapy, there are women, the good majority of women are candidates for that.
Okay. And let's talk a little bit about what menopause looks like, because we know the dreaded hot flashes, but you educated me on understanding that you can onset menopause with surgery. Had no clue. Had no
Yeah.
clue, because I was told when I had my hysterectomy 13 years ago, oh, you're just hot natured. But I'm falling out at night. I'm sweating. I have to sleep with a fan on. So you literally helped me relieve my mindset. So can we talk about some other symptoms and onset, like how is it tested for to determine?
So, there is this thing called perimenopause that
Mm-hmm.
women enter about 10 years roughly before they stop having their period. So by definition, menopause is the you've gone 12 months without having a menstrual cycle. When you get
Okay.
12th month, then you are considered postmenopausal, right?
Okay.
Leading up to that, you're in what we consider perimenopause. And that usually is marked by changes in your menstrual cycle. You can have hot flashes, but they may not be as severe. You can have
Mm-hmm.
all the symptoms of menopause, but they kind of come and go, and
Mm-hmm.
they're in and out of your life, right?
Mm-hmm.
So once you become menopausal is when things really start to change. So in that perimenopausal period, you'll notice that it becomes more difficult to lose weight.
Mm-hmm.
Our fat is redistributed in places, particularly around the midsection for most women, and it becomes more of a challenge to lose that. So in cases where someone has had a hysterectomy, and let me just educate the listeners for a moment. In GYN world, when we say total hysterectomy, we really are just referring to your uterus, because
Mm.
hystero means uterus. In
Okay.
layman's terms, when you all say total hysterectomy, you mean ovaries and tubes and uterus. So if
Mm-hmm.
somebody just had their uterus removed and their ovaries remained, your ovaries are your hormone making machines, right?
Right.
So you can continue to produce hormones if your ovaries are in. If
Mm-hmm.
everything is removed, then in essence, you have undergone what we consider surgical menopause. So now your body has you no longer have the machines that are producing those sex hormones that we think of when we think of symptoms related to menopause. And the biggest concern around that is that we're seeing younger women having hysterectomies,
Yeah.
things like endometriosis, where they're having ovaries removed. So you can have some women who are menopausal in their late 30s. And the
Mm-hmm.
concern around that is that they have a much longer period in their life that they are going without hormones. So their risk of all the things that we think about when we think about menopause, bone loss, uh, Alzheimer's disease, cardiovascular disease, all those things, vaginal atrophy, all of that is greater for them because
Mm-hmm.
started at an earlier age versus the average age of natural menopause is about 51 on average.
Oh, okay. Okay. That was a lot of really good information because you hear people saying, "Did you have a total hysterectomy?" And I'm like, well, it had to be a total because I don't have a uterus. I don't have the ovaries. I don't have fallopian tubes. I don't have any of that. But I now that you explained it, it's the removal of the uterus.
Correct.
You can still have all of the other parts. You just, can't have no more kids
Correct.
in essence. And
Correct.
and so when you find and you mentioned something, because I was asking my daughter, I said, what's a really good question to ask, because she's a ICU nurse, and I said, what's a really good question to ask about menopause from a young person's perspective? And she said, how do you help these young people who are having surgeries, endometriosis, it could possibly be an accident or something of that nature that led to them losing their uterus? How do you help them prepare for that longevity in menopause?
That's a really good question. I think that the onus is on the physician that's performing the surgery. And
Okay.
as a gynecologist that performs GYN surgery, I always take into account um, what I'm doing the surgery for, and is
Hmm.
the benefit to leaving one or both of the ovaries, particularly
Okay.
younger women. Endometriosis is a disease that usually requires both ovaries to be removed. I have had
Okay.
patients come in to see me and they have had just one ovary removed, and there's a higher chance that they may have to have another surgery or other
Mhm.
medications because of the nature of that disease, right?
Yeah.
You're having a hysterectomy, say for fibroids, or
Mhm.
because your pap smears have been persistently abnormal, those are indications where you could leave your ovaries in place. It used to be, when I was in residency training 100 years ago, that if a woman was 45, we would just automatically take everything out to minimize
Mm.
their risk of developing ovarian cancer. So ovarian cancer is the one GYN cancer that is considered to be, well, they're all deadly, but it is the deadly
Right.
of them. It is the one that is often diagnosed later. And so when people
Hmm.
are usually in the later stages. So we had gotten into this practice where if you were 45 years or older, we just automatically took out your ovaries. We don't do
Mm.
that as much anymore now that we have a better understanding of the value of retaining your own hormone production with your ovaries. So I just basically leave it up to the patient. If they have a family history of ovarian cancer, that's a different story because that puts them in a
Right.
risk category. But if they, at their baseline, don't have a family history and they're otherwise healthy 45-year-old that's having a hysterectomy for a reason other than ovarian cancer or ovarian tumor of some sort, or reason to take out their ovaries, then I educate them on the fact that if I should take out your ovaries, then that's
Hmm.
going to put you into menopause sooner, and the risks associated with that as it relates to bone loss and all the other things that we know of. And you asked me a question earlier that I don't think I answered, which was around the symptoms of menopause. And so,
Right.
the most common one is hot flashes, right? That's
Hmm.
what everybody automatically associates with somebody being menopausal. But there's brain fog, there's difficulty sleeping, there's mood change and irritability, there's joint pain, there are headaches.
Hmm.
As you listen to me tell you these things, they're all very broad, right? So there are other reasons that you could be having headaches other than the fact that you're menopausal, but certainly that is one of the symptoms that we do think about when we think about menopausal symptoms.
Okay. And how do you assess? outside of a woman not having a menstrual cycle, are there any tests to determine if someone is perimenopausal or menopausal?
Well, perimenopause is there's not a blood test that's going to tell me that you're
Okay.
perimenopausal. Basically diagnose that based on age and symptoms,
Hmm.
right?
Okay.
If you come in to see me and you haven't had a period in 6 months and you're like, I wonder if I'm menopausal and can I come off my birth control pills? Because we have some women who are on birth control pills, because don't forget now, that's one of the most common times in a woman's life for them to get pregnant is in that
Right.
perimenopausal phase. And they're thinking, oh, I can't get pregnant, and next thing you know, they're having this look
Hmm.
at age 46. But there is a test that we can do that will tell us whether or not your estrogen level is in decline or if it is sufficiently low enough that suggests that you may be menopausal.
Okay. Okay. But for individuals that have had some type of surgical procedure to remove the uterus and possibly the other reproductive organs, is it to be assumed that that is going to trip them into menopause?
Oh, it is.
Okay,
If I take out your uterus and then for giggles, I take out both of your ovaries, you are menopausal. You are now
got
starting
you.
to be menopausal. So there would be no reason for me to do any blood tests to confirm that, unless of
Mhm,
course, you are interested in doing something like a bioidentical hormone, where we oftentimes will do blood tests. And that's kind of controversial. I will say that there are a lot of organizations that, have they kind of give bioidentical hormones a side eye, particularly blood tests that determine what your levels are and help them
mhm.
determine what your dosing should be. But there is some place for that, I do believe.
Okay.
But
Can you explain what that is? What the bioidentical testing is?
yeah, so first let me just say bioidenticals basically refer to hormones that look biologically like the hormones that
Mm.
your body used to make. They are usually derived from a plant source. That is very different from um, 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 things like Premarin. So Premarin is the great grandmother of estrogen, right?
Oh, okay.
She was the first. And Premarin, Prempro, Premphase, those have a type of estrogen that is derived from the urine of pregnant horses, which is why they call it Premarin, pregnant
Okay.
mares. So that's where the name came from. So
Okay.
that that estrogen has since, derived and grown. And so we've now gotten to the point where we have different types of estrogens that we use in estrogen replacement therapy. And so bioidenticals are ones that are from a plant source, presumably. So
Okay.
world of bioidentical hormone replacement therapy, when you think of things like creams or pellets or tinctures or troches, which are lozenges. Um,
Hmm.
there is a subset of doctors who will test your hormones and determine what your dosage would be based on your levels. Um,
Oh, okay.
and then you are that medication is compounded for you in one of those modalities, and
Hmm.
monitor your levels and your response to the medicine to see how you're doing and whether or not you should stay at that level or not.
Okay. And how does that differ from hormone replacement therapy?
It doesn't really. So
Okay.
there a hormone, and we've gotten away from using hormone replacement to just
Hmm.
using hormone therapy, because replacement suggests that we are replacing exactly what your body once used to make. And that's
Got you.
almost impossible. Like I can't
Hmm.
give you enough hormone to make you get pregnant if you're
Hmm.
55 or 60, right?
Right, right.
I
Which
can
I can't imagine too many 60-year-olds that want to. There's probably some.
Well, there are
Okay.
some women who've never had babies, and I've had a couple in my practice who are in their late 50s and 60, and they want to entertain the idea of having a baby. And there are
Okay.
ways to do that, but not through my practice. Let me just say.
Hmm.
Um,
Okay.
so, with regard to replacing it, it's basically, and I use this term all the time. My role is to find your sweet spot, and that is the
Mm.
place where your symptoms are alleviated and you have the least amount of side effects. And so there, because nothing is without side effect, right? Whether you do
Mm-hmm.
something or you do nothing, there's always a circumstance that goes along with that.
Mm-hmm.
And so even with hormone replacement therapy, whether you do what we consider conventional hormone replacement or hormone therapy, or you do
Mm-hmm.
bioidentical, there are potential risks and complications. And if you choose to do nothing, then it
You
you,
just suffer the
exactly.
wow.
There are circumstances that are aligned with that as well.
Okay. I remember a couple of days after I had my hysterectomy, I think I experienced my one and only major hot flash that caused me to run out of the bed to the shower. And I kept saying, it feels like hell. If and I couldn't shower enough, and I wasn't supposed to be in the shower because I had these fresh stitches, and it was horrible. And so in situations like that where
No one
someone
prepared you for that. Your physician never had that conversation,
no,
and that's the disservice.
and that's what was so frustrating, because I think that if I had been mentally prepared that this could happen, then
Mhm.
I would have been at a better place to process it, know what to do, and things of that nature. How do you prepare your clients as they're preparing in an instance where they have to have their hysterectomy, have to have a hysterectomy? How do you help them prepare for life after?
Wow. So, that's a good question because having just had surgery myself,
Hmm.
I don't know that anybody can prepare you for, because everybody's experience is going to be different, right?
Yeah.
But what I do know is, like, if I know that I'm taking out your ovaries, then
Hmm.
part of the conversation is going to include the fact that you will begin to have menopausal symptoms. And that is different for everybody too. So
Yeah.
it could be a week, it could be 3 months,
Hmm.
after you have your surgery. It nobody really knows. But I kind of basically let them know it is going to come, and it's going to come very quickly. It's not going to
Mm.
natural menopause where you just kind of your symptoms kind of come and go, like we said at the beginning, right? In perimenopause, your symptoms wax and wane, they come and go. When you have surgical menopause and everything is removed all at one time, it kind of sneaks up on you, and then wham, it's like
Yeah.
getting out of the shower that night and run
Hmm.
and run into the shower. That's kind of how it shows up. And
Hmm.
so I try to usher in that conversation to say,
Okay.
this is what is going to happen. When it's going to happen, I don't know. And
Hmm.
if hormone therapy is something that you want to consider, then we can address that at your post-op appointment
Okay.
and decide what is going to be right for you. So as
Hmm.
we talk about the potential risks of being on hormone replacement, I keep saying hormone replacement therapy,
Yeah.
even though it's hormone therapy.
Hormone therapy. Hmm.
Things that we know is that there is a potential risk of blood clots because estrogen has the potential to cause.
Okay.
We know that from birth control pills, and
Hmm.
I'll come back to that in a second.
Okay.
Um, we know that in women who have a significant history of breast cancer in their family, or
Hmm.
carry the breast cancer gene, we're a little hesitant about giving them estrogen as well.
Okay.
Even though some people don't consider it an absolute contraindication, it's a little dicey, right? If you tell
Okay.
my grandmother, my sister, my aunt, they all had breast cancer, I probably wouldn't want to recommend that you be on estrogen.
Right.
And so, and again, clotting. If you've ever had a blood clot in your leg or a blood clot
Hmm.
in your lung, you're not a candidate for hormone therapy. If you if you have liver disease, you
Hmm.
likely are not a candidate for particularly oral hormone therapy because we know
Okay.
the process through.
Hmm.
So when we talk about the breast cancer risk, because that's always the one that everybody's most afraid of, is that it's going to give me breast cancer.
Mm.
Now know is that if you have a baseline, normal baseline, like 1 out of 9 women get breast cancer, then your risk of getting breast cancer from being on hormone therapy is not significantly reduced. I mean,
Got you.
right? But if you've got a family history or you carry the gene, something that already raises your risk above baseline, then we're a little more cautious. Um,
Okay.
with
Okay.
if you've got a uterus, the
Mm-hmm.
side effect associated with hormone therapy is irregular bleeding. And that irregular bleeding can last from anywhere from 3 months to a year. And that
Wow.
may look like you start having a period again, or it may
Mm-hmm.
look like you have this irregular bleeding that kind of comes and goes. Um,
Mm-hmm.
and so that is one of the side effects, if you will, or consequences of starting hormone therapy. But as I mentioned, birth control pills, what we know is that you get more estrogen in a birth control pill than you do in most hormone therapy regimens. So
That's
we
interesting.
women who've been on birth control pills their whole life and they're not afraid to take that. But then
Yeah.
become menopausal, they're cautious about hormone therapy. And again, it goes back to the rhetoric from
Mm-hmm.
the study that we talked about before, what they've heard, that narrative playing over.
Mm-hmm.
It's going to give me breast cancer. It's going to cause me to have a stroke and all that other stuff. Um,
Mm-hmm.
they're scared of that, but they're not scared of birth control pills that they were on since they were 16.
Lack of education, lack of knowledge, lack of understanding, lack of professionals helping to understand. I think comes into play because I remember when I had my vaginal prolapse surgery. Um, I was afraid to use the estrogen cream.
Mm.
And the doctor was like, "You're going to have to use this estrogen cream. We got to put things back in place. We got to make sure that things are moving." And I had the conversation with her, and she said, "I'll be very honest with you. What you just shared, birth control has more estrogen in it than this cream." So I'm glad to hear you say that so that more people can become knowledgeable about what's really going on. And I know we've talked about um, hysterectomy being an onset of menopause, but people still, they are right at that brink where they're 11 months without a cycle, and then boom, here comes the cycle. What is that phase called?
That's still perimenopause.
Peri. Okay.
That's
Okay.
still perimenopause. And I have seen that a lot in my practice. Somebody thinks, yeah, I'm home free. I've been 9 months, 10 months, 11 months, and then all of a sudden they have some bleeding episode. But it's also important to make sure that there isn't some other reason why you're having a bleeding episode.
Mm-hmm.
An instance too, because it is rare to go that long and then all of a sudden start back having a regular cycle again. Usually once you
Yeah.
month 11 or 12, you're kind of home free. Um,
Mm-hmm.
we have to evaluate for other causes.
And I usually tell clients when they bring that up to me, of course, I'm not a medical provider, but mental health. When they bring it up, the first thing I share with them is, hey, let's assess your stress level,
Hmm.
because that could be impacting you, causing everything to reactivate, and then go back to your doctor and have a conversation to make sure there isn't any underlying medical condition that may have been missed. And,
Yep.
and I think it's important that as women, we have a voice in the provider's room, that we can talk to our providers and expect to be educated on what this needs to look like, in our lives. Because if we don't, who else is going to tell us? We're just going to fumble through. That's what I did with vaginal prolapse. I just fumbled through it.
Well, you can address that better than me because I think that there's historically, um,
Mm-hmm.
there is a distrust of the healthcare
Yeah.
system amongst African Americans,
Mm-hmm.
understandably so. I think
Mm-hmm.
it is critical um, for all Black people, not just women, to find a provider that they trust,
Right.
um, and then listen to them. I had this
Mm-hmm.
conversation yesterday with a patient of mine, and I was talking to her about the fact that I'm wanting to retire
Mm-hmm.
time. And she said,
Soon.
soon, although, and she says, well, no, you can't retire. And I said, medicine has just really changed because with the internet and all these TikToks and all this other stuff, most people get their information not from the physician that they've developed a relationship with and they trust. They go online. I've had patients come in to see me and I'll give them all the information that I just gave you, and they'll say, well, I think I'm going to do my own research. And I'm thinking to myself, like, What research are you gonna do that I didn't al that I didn't already tell you? Like, what site are you gonna go to that
Hmm.
going to say, "Oh, this is truth, and what Dr. Orr told me isn't." So, that's kinda where we are in medicine right now. So, I
Mental health too.
exactly, exactly. So, it creates this it creates a a an inability as a provider who specializes in this to get across to people who need it the most, right? Because we talked about Black women at the outset of this. When you think about one of the benefits of hormone replacement therapy, particularly if you start it early, because
Hmm.
there is an age with which you should not start it, and most people
Oh,
agree
okay.
around 60. So for
Hmm.
most of us, we are not starting 60-year-olds on hormone therapy. If you've been on it, you can stay on it past 60,
Hmm.
but you cannot be a new start at 60. And what's happening now, since there's all this conversation about menopause, I'm getting 65s and 70-year-old women coming in talking about, well, I wasn't going to do it before, but now I just can't. I'm still having these hot flashes. And I can't give them anything hormonal. I can direct them to non-hormonal things and
Hmm.
that, but we can't do it at 60. So one of the benefits of starting it early is a reduction in cardiovascular disease, heart disease.
Mm.
And
Okay.
who's at the top of that list? Us.
Yeah.
Diabetes, metabolic syndrome, hyperlipidemia, all of that stuff, that puts you at your baseline for
Hmm.
increased risk of heart attack and stroke. If you choose
Wow.
to get on some form of hormone therapy, it can lower that risk to some degree. So when
Wow.
you think about why people should consider hormones,
Hmm.
stuff is affecting your body that you don't even feel and know is happening until it's
Hmm.
happening.
Hmm.
You have Alzheimer's disease until you got it, and even then you might not know you got it. And
Very true.
right, you
Hmm.
now you have osteoporosis. Your bones don't hurt. There's no pain with osteoporosis. You go in, you get screened, you find out your bones are thinning or you've lost bone.
Hmm.
Hormone therapy can benefit you in that regard, as well as lowering your risk of a heart attack. You don't know you're having a heart attack till you're having one. But if you
Exactly.
got all of the risk factors for a heart attack, it's best to do all that you can that's going to lower that risk. And hormone therapy is a potential risk lowerer
Yeah.
for us in particular.
Wow. And that's so good to know because from the mental health side of things, I often share with clients that when we have unprocessed trauma in our body, it begins to attach to its organs. And so when you think about that and you think about that attachment to your heart and cardiovascular
Yep.
issues, and then you add in menopause that's untreated and your fear of everything, you add in the depression and all of that, it's so important for us to create spaces to have conversations about things that had been taboo in our grandparents' history, our parents' history. They just didn't talk about it. We
Right.
need more providers that are being open and honest about what these changes of life are, how
Mhm.
that irritability, that brain fog
Yep.
is going on. Is there anything? I know when I was younger, I used to take a lot of ginkgo biloba. Yeah. And because I admire my brain, I'm conceited that way. But is there anything that people can take that could help reduce brain fog outside of hormone therapy? Or does hormone therapy help with like the brain fog, the mood reduction and swings, things of that nature?
Yeah, it does. Hormone therapy does help with brain fog. It's believed to be that you get benefit from it from both estrogen and testosterone to some degree.
Okay.
Um, I think the biggest thing about preventing brain or minimizing brain loss, and you know this, I'm sure you probably tell all of your clients this, is to make sure that you're keeping your brain active, right? Like doing things like puzzles and reading and
Mm-hmm.
things that require you to think
Mm-hmm.
are gonna help keep your brain function in
Absolutely.
your later years. There are supplements, things like CoQ10, which are thought
Okay.
to be good for your heart as well as your brain, omega fatty acids, which are good for your cholesterol in your heart as well as your brain. But those things don't alleviate the symptoms of the brain fog, so to speak. They're just kind of
Okay.
in terms of reducing the risk of brain loss,
Okay.
dementia, and that sort of thing.
Okay. So I want to pivot just a little bit for a short period about the weight loss and weight management part of your practice. Can you share with us about that portion?
Yep. So there's no secret that obesity is an epidemic in this country. Most women experience their biggest changes in their weight in and around childbearing,
Mm-hmm.
a baby, and then when they become menopausal. There's a redistribution of the fat. So some people don't feel like they've gained weight, but they just notice that there's fat in places where they didn't have it before.
Yeah.
The downside of this is that even though we as healthcare providers know that obesity is an epidemic, it's a chronic disease. It's just like diabetes and
Mm-hmm.
at this point, right? But getting the insurance companies to cover the medications has been a big challenge. So most people are familiar with phentermine. It used to be when I was in training, you could only give phentermine for a period of time. Now you can give phentermine indefinitely. People can take it all the time.
And that, for me, it hadn't worked. My
Well,
doctor keeps playing with things because it's like it hadn't worked for me.
Well, and that's what I was going to say. It's a stimulant, right? And so
Mm-hmm.
kind of like tier one. And then
Mm-hmm.
into things like Contrave. And then of course now there are all the raves with the GLPs,
Mm-hmm.
revolutionized weight loss. Like people are losing weight, almost as much weight as they would have lost if they have had bariatric surgery for
Mm.
bodies.
Mm-hmm.
Challenge is again, they're getting the insurance companies to cover it. And two, if you've been watching the news, there's an ongoing shortage of it.
Right.
They can't make enough of it, right?
Mm-hmm.
And so I do prescribe those medications in my practice. Of course, I encourage people to build that healthy muscle by proper diet and exercise because
Mm-hmm.
you want to try to maintain what you're losing, particularly with the GLPs. You can have a lot of muscle loss. So
Mm-hmm.
important that you have a diet that is pretty high in protein. And then for menopausal women, everybody wants to get on the treadmill or get on their Peloton, which you should, because that's cardiovascular. But the
Mm-hmm.
focus really should be on resistance training and strength training because
Okay.
it's going to help to tighten and tone your muscles. But it
Mm-hmm.
helps, as we get older, for me, I think the thing that I'm most focused on is I want to be able to be as independent for as long as I can. I don't want to have
Yeah.
my kids and I don't want to have to go into a nursing home. So
Mm-hmm.
strong, right? If you have adequate muscle strength, you can pick yourself up off the floor if you fall, right? You can
Right.
get out of the car if you need to. When you lose that muscle mass, which is what happens as you age and or if you're on some of these medications, you lose strength. And so I always encourage my menopausal patients to do resistance training, yoga, Pilates. Make sure that that is maybe 50-50 or 46
Okay.
in terms of your exercise routine.
Perfect. This was a lot of great information. I cannot believe this 45 minutes flew so fast. Thank you so, so very much.
For having this conversation because I think this is how people are going to start to realize the questions and what
Mm-hmm.
answer. And like I said, for so long, no one's really been talking about menopause. Now, in the last 3 years, everybody's talking about it, but it's still finding those safe spaces where you can get the information that you need and ask the questions that you want to ask.
Yeah, and you made it so very safe to have real conversation, and that I appreciate. I know my audience is going to appreciate it. Do you have any closing words today, Dr. Orr?
I would say my closing words would be, and I was thinking about this earlier today, menopause starts with me.
Mm-hmm.
Two letters in menopause. And I
I like
think that, a lot of women are afraid of it. They're apprehensive because they don't understand it. but it's just another life transition. And it is for most of us, it's the time where our children are grown and, you're empty nester, if you're married, you're alone, you have that opportunity to rebuild that relationship with
Mm-hmm.
the other. And so, and to take care of yourself and take the best care of yourself. It's different. You're not the person you were in your 30s and 40s. It's a life transition, and it's okay. It's a good season to be in. And so I think if people just look at it from that perspective and embrace it from that perspective, then they'll take the best care of themselves.
I love that. I love the me. Take care of me. Put me.
And it starts with me or men, just depends on how you want to look at it.
I'm gonna roll with me in pause for now. It's simply because I know that as women, we're conditioned for the most of our life to take care of everybody else except for ourselves. And I
Yeah.
think that as we make these adjustments and move into various stages of our lives, it's important to get back to me. So
Yeah.
thank you. If they have any further questions, do you have a website that they can go to for Q&As or any contact information you can share?
Yep. So my website, I don't know if they can do questions on my website. That's a good question. I might have
Well,
to
you have some QAs on your website, I think.
my Facebook page. So if
Okay,
you go to either Facebook or Instagram, it's Charleston Women's Wellness Center. It's Charleston, South Carolina. It's spelled just like that. And the Instagram is the same thing. And you can ask questions. We post menopausal facts and things on the Facebook page often. We do little quizzes. And then you can go to my website. It's cwwc.com.
nice. Thank you again for joining me. I truly, truly appreciate this very open conversation. And I may get you back. We may have to do a bring back, depending on what kind of questions we
Yeah,
get and things like that.
sexual health side of
I
it.
was gonna say we missed the whole part on
Oh,
sexual health. So definitely we may schedule again and I may do a two-parter right behind each other. So we'll get our calendars together to do that. I'm elated that this conversation has begun and that we can delve into the depth of women's health, women's understanding, and being able to learn how to get some control of these hot flashes, these mood swings, and these brain fogs. We can do this, ladies. We really can. So thank you again. Thank you all for tuning in to Authentically Peculiar with Marcia. Take good care. Don't forget to like, subscribe, comment on all things Authentically Peculiar. Bye.